Great. Well, I will officially call us to order. It's 1 p.m. according to my clock here. So welcome everyone to our Caregiver Skills Clinic on the topic of medications. If you are not familiar with our education program and our skills clinics in particular, this is something that we offer on a regular basis where we provide family caregivers with the same type of ideally sort of hands-on practical caregiving skills that a lot of professional caregivers are taught. These days, of course, we have to do this via Zoom, so it's a little less hands-on than it used to be, but we're very happy that you're here. We'll make this as interactive as we possibly can in the Zoom webinar environment, and we're very grateful for your attendance here today. My name is Amy Abrams. I am the Director of Education with Alzheimer's San Diego, and I am very pleased today to be co-presenting with my longtime colleague and a tremendous resource here in the San Diego community and actually nationwide now, Dr. Stephanie Matinpour, who is a Board Certified Geriatric Pharmacist and a consulting pharmacist who knows a lot about her topic. Welcome. Couldn't hear you. Your audio is working, right? Oh, there.
Thank you so much.
Yes, great. Okay, we will, on the topic of technical issues and all of that, we've got support here today in the webinar with us. One of our volunteers, her name is Tanvi. She is a member of our volunteer tech team. She is available if you need any support during the program, if you're having any difficulty with your audio, the screen setup, you're having difficulty seeing, hearing, chatting, whatever it might be, please reach out and let us know. So without any further ado, we'll go ahead and get started on our program here. This is the broad overview of what we're going to be talking about here today. I'm going to start off by providing a brief introduction to the brain changes in dementia that make managing medication safely so difficult for a person who's living with Alzheimer's or another type of dementia. Then we'll get into some sort of caregiving techniques for supporting somebody who is living with memory loss, other cognitive changes, helping them manage their medication safely. We will break to take some questions if any have come in. And then I will turn things over to Dr. Matampour, who will talk about some of the common questions that we receive regarding medications and other sort of non-pharmaceuticals that are prescribed or purchased over the counter for dementia symptom management. We will talk about medication safety and storage, and then we will pause again for more questions that you may have for Dr. Matinpour. So, and then we'll wrap things up by making sure you know where to go for more information and more help. So let's start by talking about the brain changes in dementia that impact a person's ability to manage their medication safely. So this is not a program about Alzheimer's disease or other types of dementia, the pathologies of the disease. We have other education programs that cover that in some detail. I just want to talk today about sort of what's going on in the different regions of the brain that make the management of one's own medications so challenging for a person who is affected by one or more of these conditions. So do know that I am speaking here about people who are living with Alzheimer's or another non-Alzheimer's type of dementia, people with mild cognitive impairment, or people who don't have a diagnosis, but are experiencing changes in their memory and their thinking and their cognition for other reasons. So most Alzheimer's disease and most forms of dementia tend to start in the temporal lobes of the brain, in the center of the brain that are primarily the seat of our memory, in particular our short-term memory, and a lot of our language ability is centered there as well. So when there is damage in the temporal lobes of the brain, the memory impairment may cause a person to forget that they've already taken a medication, forget that they haven't already taken a medication, forgetting why they even need to take that medication in the first place, right? A person may actually not even remember that this is a prescribed medication that they've taken for 6 months, a year, 2 years, that this is in fact a critical medication for their safety. So that type of rapid forgetting or longer term forgetting, both will affect a person's ability to manage their meds safely, as well as that disorientation, not being certain or frankly feeling certain, I have already taken my medication today, I don't need to take this, right? When there's damage in the frontal lobes of the brain, this big region up behind our foreheads, and most types of dementia do spread. They spread beyond the temporal lobes. They move into the frontal lobes, up into the parietal lobes, and then toward the back of the brain. In most types of dementia, every region of the brain is going to be impacted eventually. And when it is, we'll see different types of symptoms emerge. So when there are behavioral symptoms, we may see a person refusing to take medication because they have apathy, right? Very low energy, low motivation, difficulty initiating, getting started with things. I just don't feel like it. Can we do this later, right? Every time you ask. Or there may be active resistance, right? Both of these are forms of resistance, just saying no. But if a person is actively saying, no, I don't feel like doing this right now, we'll do it later. Active refusal, pushing you away, being a bit argumentative or combative, that's going to make the management of their medications very difficult. As the disease moves into these sort of upper and back regions of the brain, we see more difficulty with other cognitive tasks, thinking, solving problems. Recognition is one of those problems that we'll see, especially when there's damage up in the parietal lobes, up here in the crown of the head. So what that can cause is difficulty recognizing the difference between two pills, right, that might look very similar. Knowing the difference between a bottle of my medication versus the medication of somebody else in the home. Being able to tell which of these medication boxes that's set up, for example, is mine, or is the box for the morning versus the box for the evening. All of that, think of just how complicated it is to manage one's medications. All of that is made much more difficult, if not impossible, when there is damage from these diseases in these regions of the brain. So we'll see sort of global difficulty with problem solving. It could be something as simple as getting the pill box or the pill bottle open. But usually it's more abstract than that, having more difficulty with sequencing, knowing the order in which do I take the sip of water first before I put the pill in my mouth, right? Being able to sequence how and when one needs to take one's medications can be affected. And then, of course, there are physical symptoms of dementia as well. So when a person is losing manual dexterity, being able, the connection between your brain telling you to do something and your body, specifically your fingers, executing that, right? So losing dexterity makes the management of medications very, very challenging. Difficulty with swallowing, I'm going to talk about in some detail here in a bit. A very common symptom, especially in the late stage of dementia, but it can happen in other periods and other stages of the disease as well. Difficulty with swallowing, of course, it will make for being able to take one's medications as scheduled more challenging. And then notably, many people with dementia, and not just in the late stage of the disease, pretty early on will experience a significant narrowing of their visual field. And this will make it very difficult for a person to be able to take in visual stimulus, to know this is my pill, to be able to get it out of the box, to sort one's medications correctly in the first place, to know that you're taking the right pill, the right dosage at the right time of day, and being able to have the dexterity to take it safely. So just a quick overview of what's happening to the person's visual field. This is a very common symptom in all forms of dementia, where what we'll see is a significant narrowing of this peripheral field of vision. So if you're standing and looking at this beautiful vista here, and you don't have any brain changes related to dementia or other visual field problems, you can take in the whole scene here. if you are living with early stage dementia, very early stage even, we call this sort of scuba view or tunnel vision. It's as though you are looking at that landscape or whatever you're looking at through a set of swim goggles, scuba goggles, right? You have a very limited frame of reference for everything. Clearly, you can see much less of that scene, and something that is your depth perception can get really thrown off by this narrowing of your field of vision. So being able to tell how far away something is, right, it's going to become more and more difficult. And as the disease progresses, for many people, not everybody, but for many people, that field of vision just shrinks dramatically. In the middle stage, it's as though the person is wearing a set of binoculars. Imagine the impact that this has on many self-care tasks and not just medication safety, right? In the middle stage, we're down to kind of monocular vision. It's not that the person can't see out of both eyes, but the brain is having a hard time processing information coming through both eyes at the same time. So in that mid stage, the person can focus on kind of one task at a time. I might be able to sit at the table and focus on what I'm eating or the medication that I'm trying to get into my mouth, but I can't really concentrate or pay any attention or maybe even see anything else that's going on in my environment. And then in that mid to late stage, as things are progressing even more, my vision is so limited that, or my field of vision is so limited that I'm beginning to have what we call object confusion, not being able to tell the difference between my pen and my fork, for example, my morning pill versus my afternoon pill. In the late stage, very near full vision loss is not uncommon. So I hope that explains not only why medication management can become so complicated, but actually this is a helpful thing to keep in mind when it comes to lots of different types of caregiving and supporting people who are living with dementia. They're going to respond to our attempts to be helpful in ways that we might find confusing or startling. And if you can keep this in mind, this will allow you to make a different kind of an approach. A quick note on swallowing impairment, dysphagia, dysphagia, it is pronounced, I have recently learned it's correct either way you say it. I was trained with dysphagia, so that's what I like to say, but let's call it swallowing problems, right? This is very common, especially in the late stage of dementia, as the disease is sort of reaching the cerebellum, the brainstem, those back deep regions of the brain. Swallowing impairment is related to changes in the cortical regions of the brain. And what it means is that the person is beginning to experience a lot of difficulty taking in very thin liquids or food that has not been broken down into smaller pieces or pureed. Again, common in late stage dementia, but the changes can start earlier. So for many people, this manifests as coughing, choking. You may hear that sort of gurgly rattle where a lot of saliva is collecting over the vocal cords, not necessarily something to worry about unless the person is coughing and choking when they're eating and drinking. Of course, that's a significant issue. And of course, it's going to affect a person's ability to swallow medication in addition to being able to swallow your own saliva, thin liquids, and food that you're eating. So swallowing problems are a significant care concern for people who are caring for or supporting somebody who's living with a progressive form of dementia. Because for many people, the ability to take in food and liquid is going to become significantly impaired as the disease progresses. And you have to be thinking about things like the possible need for artificial nutrition, hydration, and of course, earlier in the disease process, these complications related to being able to take medication safely. So we will be talking about medications can sometimes be given in different forms for somebody who is having swallowing problems. The risks of untreated swallowing impairment at either in a younger person who does not have dementia or in the late stage of dementia, we may see malnutrition because it's difficult to get enough food, dehydration, when it's difficult to drink enough fluids, And the risk of aspiration pneumonia is exceptionally high, especially in people in late stage dementia, where saliva, food, liquids are getting into the lungs, going sort of down the wrong pipe, if you will, and then the body can't really fight the infection and developing pneumonia. So lots of implications here, not just related to medications, but certainly related to medication safety. So now I'll talk briefly here about some general techniques for assisting a person who's living with dementia in taking and managing their medications. And we will be pausing for questions in a few moments here. So if you have questions, please, you don't have to wait until we get to the Q&A. You can go ahead and type those in at any time. So this is a concept I like to highlight in a lot of our caregiving skills clinics on a variety of topics. And that is just sort of and thinking big picture and long-term about the progressive loss of function that dementia causes. This is one of the things that makes caring for somebody who's living with Alzheimer's or another type of dementia different from caring for somebody who is living with a different type of illness, an injury from which they are recovering, for example. Most types of caregiving that we do in our lives, when we're caring for children who are developing, or we're caring for adults who are recovering from something, we come at that caregiving with a perspective of really wanting to challenge the person to do as much as they can do because they're learning or relearning, right, skills. Unfortunately, this is not the case for a person with a progressive form of dementia. I showed you the sort of progression of the pathology through the brain. At the moment, we don't have medication that stops that progression. We have to plan ahead for a time that a person is going to require total assistance with personal care needs. So it's, as care partners, we don't want to be sort of challenging a person with dementia to do more than they're really capable of doing. We don't want to push to the point of failure the way that we do when we're sort of pushing and supporting somebody who's growing, developing, or rehabilitating. There's a difference there. So our goal in supporting someone with dementia, it's not to take away their ability to do anything for themselves. By no means do I mean that, but our goal is to help people be as autonomous as possible, as in control of their medications, what they're taking, what they're not taking, when they're taking them, how they're taking them, allow them to have as much autonomy and a sense of control as they possibly can. Our goal is not to sort of push them to the point of being independent or to get them back to a former state of independence. Unfortunately, that just isn't a realistic expectation. Having said all of that, what we want to do is to try to do things with the person, not do things to them, and not do things for them. No, you're setting these medications up all wrong here, let me do it, right? That may be the actual situation. They may be setting up their medications wrong. This may be an unsafe, dangerous situation, and you need to intervene, but it is not going to be helpful if that's what you're conveying to the person. You're doing this all wrong. Here, get out of the way and I'll take over and I'll do it for you. Right? We want to find ways to make what the great occupational therapist Teepa Snow refers to as making a positive approach to their care, right? Learning to find ways to go alongside the person, take those medicines together, right? Make this more of a task that we're doing together, at least make it feel that way, rather than sort of elbowing them out of the way, doing things to them. Here, take this medication, right? Or elbowing them out of the way and doing things for them. So we need to be reasonable, be flexible with regard to, and our guest pharmacist presenter will talk about the limits of being flexible when it comes to timing and dosing of medications. But in caregiving in general, it's just important that we be reasonable in our expectations. Is perfect 100% accurate administration of these medications feasible? Is it possible? And is it feasible and possible in this moment? maybe we can try it again a little bit later. So being as flexible as you possibly can. So all of that, I ask you to just sort of keep running in the background of your mind as we move forward in talking about some of the techniques. So we're going to start first by talking about the environment where medications are being set up and administered. Is the environment familiar? Is the person oriented? Do they feel safe? Is the environment functional? Is there enough space for them to move around? Is there enough space for you as the care partner to be there to support them? Is the environment forgiving? Right? These are sort of the elements of what we call a dementia-friendly environment, right? If you drop the pill in the process of setting up the medication box or trying to take it, are you in an environment where there's so much clutter, there's a lot of pattern in the carpet, for example, and you'll never find that pill? Or is it an environment that has a little more forgiveness, right? There's a mat that's been laid down, and so if something gets dropped, you'll be able to spot it, right? So when we say friendly, we mean dementia friendly. So I'm going to show you a picture of kind of a typical looking dining room, dining table. This is not my home, but it could be. That level of clutter is not totally outside the realm of normal, right? And I ask you, if given everything that I went through, those brain changes, memory loss, cognitive changes, difficulty with focus, concentration, sequencing, difficulty with fine motor skill, difficulty with the recognition of objects, and in particular, difficulty with those visual field changes that I was describing. Think back, if you are a person who's living with dementia and your medication box is somewhere on this table, right? And I, your care partner, have sent you into the dining room. It's time to take your medications. You know, they're on the dining table. I set them up for you. Right? This is a challenging environment for a person. For many of us might struggle to find our med box on that table, especially for a person who's living with dementia, to get to it, to find it, to sit down without getting distracted by some of the other fun, colorful looking things that are laying around, right? And then being able to sort of focus on the task at hand. All of this is going to be a great challenge to someone who's living with dementia. So our tips on creating a more dementia-friendly environment, of course, clutter, and I'm not just referring to the stuff that's on the table that was draped over the chairs, right? The things that can be visually distracting make a room dementia unfriendly, but also just other types of distractions. If there's a lot of sound in the room, if there's a lot of activity, right? There's kids at the other end of that table eating or playing a game together. That could be very distracting and make it hard for the person with dementia to focus on the task. If you're taking medications in a bathroom or a room that has mirrors, keep in mind that that can be very distracting to the task at hand. So you want to try to declutter as much as possible in the spaces where you're providing any type of assistance, care, support to a person with dementia, including the administration of medications. What you want to do is try to have what you need on hand, excuse me, have that there. Be prepared with the essential stuff and try to move the other stuff out of the way as much as you can. You want enough space for the person to move, but also for you as a care partner, if you're going to be pulling up a chair and sitting down together to take medications together. Excuse me. I mean, you want to have enough space. And then making sure that there's enough good, bright light. Natural light is best, but not always possible. You want light coming in from multiple directions. So it's not just coming from overhead and creating lots of sort of confusing shadows for the person to contend with. Lots of bright lighting so they really can see what they're doing. And of course, just keeping the room as comfortable as possible. That's temperature, you know, smells, activities, whatever else might be going on. All of this is what we refer to as the positive approach to care. And again, this was developed by occupational therapist and prestigious dementia educator named Teepa Snow, who developed this method called the positive approach to care. You can go to her website to learn lots more. Go to her YouTube channel to actually see visual demonstrations of the positive approach to care in lots of different care contexts. But just a quick sort of summary of what we're talking about. keeping in mind all of those brain changes that have happened, that have happened or will happen to a person who's living with a progressive form of dementia. How can you make your approach when attempting to provide help as positive as possible? Start by establishing a visual connection with the person before you move into their personal space. So if you're coming into the room to sit down and help them with their medications, instead of just sort of charging right in, sitting down right next to them and getting down to business, which is of course most people's kind of MO, pausing, making sure they see you, that they know that you're there, remembering that limited field of vision that they might have, right? Establishing some visual connection first, make a verbal connection. Hey, it's me, Amy, I'm here to help you with your medicines, or, say something so they've seen you, they've heard you, and then you have sort of their permission to enter into their personal space. A simple way of getting a person's permission to come into their space is to offer a handshake. This is a method that is called hand under hand, far more detailed than we can get into in this program here today, but a very positive way to get somebody's kind of consent and permission. Extend a hand, they extend their hand, and now you've made physical contact and you can come into their personal space to do something like help them get a medicine into their mouth, or sit closely enough, physically closely enough to provide that support. Speaking of how you're sitting, what we want whenever possible is to be in what we call a supportive position, not a confrontational position. So if the person is sitting at that dining table, for example, not standing directly next to them, sort of your head down, looking down at them. This makes people sort of cower. It makes people feel defensive and uncomfortable, no matter how close the person may be to you. It's maybe your lifelong significant other or a parent-child relationship, but that sort of confrontational position can be very uncomfortable. So pull up a chair, sit down next to the person, keeping in mind, again, that limited field of vision, and recognizing that if you're sitting in the chair right next to them, you might be right close to them. You might be close enough for physical contact, but they may not know that you're there. Because of the short-term memory loss, they may have forgotten that you're sitting right there, right? So you'll need to do things to sort of remain in their field of vision, to do things that feel supportive to them rather than confrontational. Resistance is a big topic in all sorts of caregiving. I'll be brief about this because we have a full 90-minute webinar on this specific topic. And in fact, it's coming up in just a few weeks. In early December, we'll be doing our program on managing resistance, but we have to talk about it when it comes to helping a person take their medicine safely. As best we can, we want to honor the routines, rituals, the rhythms of their life, of what's familiar, right? If they have always been an early morning riser, we want to try to honor that and keep that type of schedule for them as best we can. Providing validation and reassurance all along the way as we are supporting someone, letting them know you're doing a great job, saying yes. Showing them visually, nodding, smiling, making eye contact, a gentle touch on the hand, whatever it might be, to provide reassurance. You're safe. I'm here to help you. Or yes, you're doing a great job. You did that the right way. Providing lots of that along the way goes a long way to overcoming resistance. One of the surest ways that we can get a person to stop listening to us, to overtly resist our attempts to be helpful, is simply telling them what to do, right? Instead of kind of nagging and telling someone, no, don't do that. What we want to do is try to make our statements more positive, more action-oriented, more focused on what it is we want the person to do, not focusing so much on what we want them to stop doing or what we want them to avoid doing. So, no, mom, don't spit the pill out, right? When you say something like that, you're drawing her attention to the act of spitting the pill out, right? So instead, here, take a sip of water, right? Modeling for her what it is that you want her to do, handing her the glass. If if that would be helpful in that moment, right? Showing her what it is that you do want her to do can be very helpful. So when we talk about action-oriented language, it's this, okay, time to take our pills. Instead of getting into the power struggle of, will you take your pills now? Do you want to take your pills now or, in an hour? Instead, sort of not giving the option of, no, I don't feel like taking my pills. It's time to take our pills. Let's try it this way. If you want to give the person some choices, okay, we've got these 4 pills that have to be taken and they all are important. We're gonna have to take them all. You wanna take this one or that one, right? Just to start, right? Giving the person some autonomy, some control, some choice, some ability to feel in charge of what's going on there, but you're taking away the option where they say, no, I don't want to take any of those, right? That's what we mean when we say being action-oriented. A lot of resistance in people with dementia is really a product of confusion. You're talking too quickly, you've said too many things, you've put down this whole, box that I'm not totally sure what to do with. Which of these little panels am I supposed to open? Which one of these am I supposed to take first, right? We're giving the person far too much information much of the time. Communicating the way we've always communicated with them, doing things, saying things the way we always have is normal. It's a habit, right? Especially if you've known this person for a very long time, it's very normal to communicate with them the way you always did. But the reality is, remember, the progressive brain changes that I was describing, the progressive loss of function over time means that, and they're not in control of these changes. We're the ones that have to change the way that we communicate, the way we ask them to do things. So being very clear, being very direct in your speech, and giving one prompt, one statement, one request, one step of this process at a time is very, very helpful to sort of breaking down some of that resistance. And again, I just want to emphasize doing things with the person, not doing them to them or for them. So part of this, unfortunately, sometimes kind of comes down to what we refer to at Alzheimer's San Diego as therapeutic fibbing, right? You may not be being fully, completely honest, completely forthcoming with the person in the name of supporting them in feeling as autonomous as possible. We might be saying something like, okay, time to take our vitamins, right? If you're sure that they're not going to feel good about taking this medication because they're mistrustful of you, of the doctor who prescribed it, they don't remember what they're taking or why they're taking it, right? Maybe something like, let's take our vitamins. Maybe you don't have anything you need to take, right? I don't take any medications, but I need to support my father in helping him take his medications. So maybe I'm going to sit right down next to him. I'm going to have my own little pill box or dish or however you have things set up, but it's going to have raisins in it or Skittles or, I don't know, something, right? Time to take our vitamins, right? Whatever the therapeutic fib is that sort of gets you into a successful rhythm with that person, makes them feel good about what's happening, we call it a win. So this is challenging for a lot of care partners, but therapeutic fibbing is a really helpful technique that helps the person with dementia. In many cases, it's not about being manipulative. It's not about doing something hurtful or harmful to them. It's about making them feel better about this type of assistance that they, for their own safety, for their own well-being, that they really need to accept from you. So we encourage you to think creatively about things you can say, ways you can set up the room, set up the environment, and modify your own movements and behaviors to help the person feel as in control of their situation as possible. So with that, Ellen, I'll welcome you to come back. Let me know if there are any questions that we can answer.
No one has submitted a question about this information, but oftentimes in support groups, there is a struggle with, when you mentioned honor routine and ritual, where it used to be the individual living with dementia would be able to stand in the kitchen and take their medication on their own and not have to be watched
Yes.
to make sure they swallowed. And there comes a time when they do need to be monitored, but there's that argument for leave me alone.
Yeah.
I've always done it myself. Do you have a strategy that you might recommend for the care partner wanting to be able to either be present or monitor, and a way to language that?
Yeah, let me go back to this slide here for a moment. When I talk about providing validation and reassurance, I think this is where I would start in that situation. So I think our tendency, our inclination, our impulse in that situation, when somebody says, I don't need you to stand here, right? One of the things we'll hear a lot, I don't need a babysitter, right? I don't need you sort of hovering and watching over me. And what we tend to do in that situation as care partners is we want to explain to the person why I'm doing this. Or, well, you have a history of not taking your medications properly. And so I need to be here to make sure that you do this safely. Well, keep in mind what the person is experiencing. If they've got memory loss, if they have a condition that we call anosognosia, where the person does not have insight into the changes that are happening with them. I don't remember that I'm forgetting things. Right? I don't remember that I have this diagnosis, and that's why you're always here up in my business, right? If I don't have insight into what's happening with me, what's changing with me, you can explain all day long, why I should be accepting your help. But how useful is that to me if I don't remember that anybody's ever diagnosed me with Alzheimer's disease or another type of dementia? You telling me that I forget to take my pills, you reminding me of an incident that happened a week ago where I, spilled my pills all, down the sink, and then we had to go back to the pharmacy and get them all refilled, right? And you telling me all of these things does not motivate me to accept your help, right? Yes. I'm sure this is a familiar scenario to some people yes. In the room with us here today, right? So instead, getting into that sort of butting your head up against their resistance, which again, I just want to give everybody a break. This is a totally normal response, right? To try to defend yourself and explain to them, reason, give them a good logical argument for why they need your help. It's probably not going to be helpful. So I encourage you to turn back to this technique of providing validation and reassurance. So maybe saying something like, I know you don't need my help. You do fine with this, right? We're back to our therapeutic fibbing. The person does not do fine. They really do need your help, but do they need to hear that in that moment? Probably not. Right. So I know you do fine. I'm a worrier. I'm a worrywart. I'll just stand back here and I'll just keep an eye on things that's going to give me some peace of mind. Right. Or just providing the person reassurance. I know you do a great job. Right. You really don't need me here up in your business. This is super annoying. Sometimes just saying something like that, I'm being really annoying. Right. I can see that I'm bothering you with this. Just saying something like that is often enough to diffuse all of the resistance, and they'll go ahead and just, okay, fine. At least, you're sort of off over there. You're being annoying to me. So now at least I feel seen, I feel heard, I feel understood. And I feel a little bit like you're kind of backing off on me, and then I'll go ahead and do it.
Thank you, Amy. That's a great answer. And that's it for right now.
Okay. Well, then if we are all set with that, I'm going to go ahead and turn things over to Dr. Matinpour. And I'll go ahead and advance your slides for you. So just let me know when you're ready.
Thank you, Amy. Again, I am Stephanie Matinpour. I am a board certified geriatric pharmacist, and I have a nonprofit based out of San Diego called Pillbox Talk, where we work with caregivers and providers to help those aging in the home with their medication questions. So I'm excited today to be back co-presenting with Amy. It's been a while. COVID threw us for a little bit of a loop, but I'm excited to be able to answer some questions for people today. Go ahead and go to the next slide, please. Thank you. So we're going to start by talking about several of the medications that are currently FDA approved for people that have been diagnosed with Alzheimer's dementia. These medications look to treating the symptoms of Alzheimer's dementia and can provide patients with, comfort, dignity, and independence for a longer period of time. It's important to know and understand that none of these medications stop the progression of the disease itself. They merely help try to slow down the process. The first class of medications we're going to discuss are for what we would consider mild to moderate Alzheimer's dementia. This class of medications is called cholinesterase inhibitors. These work by breaking down the acetylcholine, which is a chemical in our brain that's important for memory and thinking. As Alzheimer's progresses, the brain produces less and less acetylcholine. Therefore, these cholinesterase inhibitors, these medications, may lose their efficacy as the disease progresses. The goal of these medications, again, is to help to delay or prevent symptoms from worsening, again, for a limited time, and help control some of the behavioral symptoms that you may see. Some of the medications in this class, Aricept, brand name donepezil, is readily available in tablet and also what we call an oral disintegrating tablet. So kind of like it melts in your mouth, not in your hand type of situation with the Aricept. Rivastigmine, brand name Exelon, is available as a capsule oral solution, and it's also available as a patch, which is a unique delivery system for this medication. And then finally, galantamine is also available in a tablet, an oral solution, and what we would call an extended release capsule. So those are kind of the three main players there. There is an older drug that some people may be familiar with that we don't use anymore because it had a lot of liver issues. So these are the three main players that we see. Tacrin is not available anymore, at least it should not be available. Maybe available in other countries, but in the US, we've taken it off the market because of some liver toxicity issues. For this particular class of medications, some of the main side effects you're going to see are your nausea, your vomiting, GI issues, maybe some diarrhea, possibly some fatigue. So usually when you're starting these medications, you're really watching for the side effects and making sure, again, that the benefits of the medication are outweighing the risks or the side effects. I mentioned, that eventually the acetylcholine effect may fizzle out with these drugs. And so it's important for you to always reassess the medication, if not annually, every couple of years with your provider, to make sure that it's still giving you the benefits that we want to see with the medication, making sure that's outweighing any potential side effects. I know in my experience, I've had many clients that I've worked with their provider to taper them off some of these medications if they've been on them for more than 3 to 5 years, because they may not be seeing the benefits that they saw the first couple years that they were on it. So always something to keep in mind to make sure you're really seeing benefits for these medications. The next class of medications that is approved, this is more for moderate to severe Alzheimer's. So as our disease is progressing, we'll often add on what's called an Nmda antagonist. The medication in this class of drugs is Nemda. And so this one works by regulating another chemical in our brain called glutamate. It's very important to brain health, but when it's produced in excess, it could lead to brain cell death, and that's where we see some of the cognitive decline. Since they work differently than the cholinesterase inhibitors, these two medications can be used together to work synergistically. So they are often prescribed together. Like I mentioned, usually you start off on the Aricept or donepezil, a cholinesterase inhibitor, and then you add on the Nmda later. But that could vary depending on what stage the patient is in their Alzheimer's dementia diagnosis. So We like to see, as clinical pharmacists, them definitely added separately, just so that we can monitor how a patient's reacting, and hopefully hone in on any side effect issues or dosing issues for each individual medication. For this particular class of medications, you're going to have a little bit more what we call CNS effects. So you may have some dizziness and headache, but you're also going to have some of those GI side effects similar to the cholinesterase inhibitors. And so again, going back to keeping the drugs separate and starting them separately is important to kind of figure out, how that specific patient is reacting to the medication and if it's benefiting them. With that being said, there is a combination medication called Nemxeric, which is actually memantidine, along with donepezil, which is generic for Aricept, which is ideal for those patients that have high pill burden. So they're taking a lot of medications and they only want to take one pill. However, you run into issues as a clinician when you're trying to figure out if it's the right dose for that patient, because there is only one strength of Nemxeric. And so we want to, again, the goal is to kind of keep them separated so that we can figure out which one is working best for the patient. But it is an option for those patients that really have high pill burden and they need to have a singular medication. Okay, I'll have my Vanna go to my next slide. A couple other medications I want to note that are FDA approved. Aducanumab is a monoclonal antibody. It is very controversial. Just was approved through the FDA accelerated approval process based on decreasing the amount of amyloid plaques seen in the brain. The clinical trials are actually still ongoing for this drug. FDA advisory panel gave it accelerated approval, but it wasn't unanimous. There was a lot of upheaval about this decision and a lot of controversy. So it'll still be probably another 8 to 10 years before we see the true outcomes of this medication. As I mentioned, it works by decreasing amyloid plaques is what they're seeing, but that's not correlating necessarily to improved Alzheimer's dementia symptoms. So again, still lots of work to be done with this drug. There's some risks with bleeding and hemorrhaging, so you actually have to have MRIs done. Significantly with this medication, you actually have to have an MRI done before you can even get the drug, and I believe you have to get like 3 MRIs within the first year of receiving this treatment. Because it's in the kind of emergency accelerated approval, I've only seen it from my perspective at this point in a clinical trial setting. They're very limited on how and who is able to access this drug because they are still looking at it. And it also would require someone to go into an infusion center. So if someone's not very mobile and not able to leave the home easily, this obviously would not be an ideal medication for them because they would have to go into an infusion center at least once every 4 weeks for the infusion. So that's that new drug on the market. The other one that was recently in the last few years released is Dexter. Again, a little asterisk with this one. It only has shown a modest improvement in agitation, and it actually has significant side effects and drug-drug interactions. Specifically in this population, it increases fall risk, which obviously we want to avoid. And it also causes what we call a prolongation of the QT interval. So if someone has underlying heart issues, this is definitely something that we would want to avoid. It's also a pretty expensive medication. And so a lot of insurance companies won't cover this medication, but it is another option that's FDA approved. And we'll go on to the next slide. So that was a quick synopsis of the tools that we have in our toolbox that are actually FDA approved. As you can see, it's very short and limited. And the next section we're going to address is dietary supplements and natural remedies, which is a Pandora's box. And I will start off by just giving my little soapbox testimonial. I've been a pharmacist for 20 years now, working in various settings. And, I can say my own opinion of supplements and natural remedies has evolved over the years. I've immersed myself in learning more about it and educating myself more about it as a pharmacist, because it comes up all the time. And the one thing I always encourage people is to be your best medication advocate. With natural remedies and dietary supplements, they are not FDA approved or regulated at all. There are several outside private companies, such as USP, the United States Pharmacopoeia, that kind of give their stamp of approval for certain supplements that have met their quality control standards. What that basically means is that they've been randomly audited, and what they say is in their capsules and pills is actually in their capsules and pills, because unfortunately this area is unregulated. Anybody can create a dietary supplement and label it and sell it, and you don't really have a good way of knowing what's in there. So my biggest advice as we go down this path is to always consult with your pharmacist, or if you have like a naturopathic doctor or a physician that's very versed in the naturopathic world and supplements, to have that person be an advocate for you, to help you make sure you're purchasing supplements from a quality source. And buying them online is often not the appropriate place to buy them, as long as it's from, again, a validated pharmacy. But we can talk about that in the Q&A later. So let's dive into some of the vitamins and supplements that are commonly linked to use in this population. So we'll start with vitamin E. So there have been some studies, and when I say studies, they're not the robust studies that you see for medications that are approved by the FDA, but there have been studies looking at vitamin E. It was looking at more like long-term combination therapy, actually with Aricept and Donepezil. And they found that taking vitamin E may potentially slow cognitive decline, but the doses of vitamin E that they were using were what we would consider very high, so exceeding the daily recommended allowance, closer to 1,000 milligrams per day, or international units per day. And so the problem when they looked at this study is they ended up having an outcome that they weren't expecting, where patients taking more than 1,000 milligrams of 1,000 international units of vitamin E a day had poor outcomes, such as mortality. So my advice with vitamin E is, yes, it's safe to take in the allotted daily use amount. And again, it may or may not slow progression of cognitive disease, but it's important to stay within the recommended daily allotment and not to exceed it. In this case, more is definitely not better. The studies have shown that with vitamin E, that more can cause you more problems. So stay within, that daily dose between 400 is the normal dose per day. If you want to bump it up to 800, that's probably fine, as long as you don't have bleeding risk or heart issues. But definitely anything past that, you would need to consult with your doctor. Ginkgo Biloba is another very popular herbal supplement associated with helping memory functionality. Ginkgo Biloba is an antioxidant, has antioxidant and anti-inflammatory properties. There's also been many studies with Ginkgo Biloba where it may potentially stabilize or modestly improve cognitive function. The thing with it is you have to take it consistently, and it could take anywhere from 8 to 12 weeks to see any effects of it. And then the downfall is that, there's significant drug-drug interactions with this medication, especially in this population where we have many other chronic disease states. It can increase your risk of bleeding. So if they're on a blood thinner or something like that for controlling blood clots or things like that, I would avoid Ginkgo Biloba. Also, there can be other interactions with other medications. So again, with this particular supplement, it's very, very important to check with your pharmacist or our provider to ensure that there's no drug-drug interactions with this one. Resveratrol, I threw on there just for Amy, because I think she's asked me this one a few times. This one's come up quite a bit too. Resveratrol is, it's the chemical found in red grapes that we make our wine and grape juice from. Also a great antioxidant, hasn't shown any data to prevent or reverse any cognitive decline. With that being said, I'm not aware of a ton of drug-drug interactions with this supplement. It does have some GI issues though. So if someone's already having some stomach problems, I would avoid it and maybe just have a glass of wine at dinner instead of taking it as a supplement. So that's resveratrol. Other supplements such as the omega-3 fatty acids, they also in excess can get you in trouble. But if you're, staying within the recommended daily allotment, they have beneficial effects, for overall anti-inflammatory and antioxidant components. But if you take mega doses, you can run into, again, issues with bleeding and stomach upset and things like that. Vitamin B is a unique one. They've actually found people that are deficient in vitamin B12 can actually have what we call reversible dementia. So I would actually, before you go out and load up on vitamin B supplements, along with many of these supplements, is you can actually go ask your provider, or many pharmacies offer these tests now. It's actually a micronutrient test where you can actually see all of the essential elements that we get in our multivitamin or from our diet that you may be deficient in. So before you go off and start buying all of these supplements and adding on to your pill burden for your clients, make sure that you're actually deficient in them first. And it's a simple test, a little blood test. And I think there's so many of these tests these days. I think some of them you can even use a finger prick. And you can get the results and see if you're actually, deficient in vitamin B. But, generally vitamin B is well tolerated, again, as long as it's not in excess. Other things that have come up in the dietary supplement world are your statins and NSAIDs. So a few years ago, there was some postulating that taking statins, which are like your Lipitor and things like that, could potentially improve cognitive function and slow progression of the disease. But those studies have not really been validated. And in my clinical practice, I've never seen a provider prescribing a statin medication for this indication. Obviously, if somebody has high lipids and they need to get that under control, that's something that we would encourage as a overall provider, but we would never want someone to use something off-label from that perspective. In that same category, anti-inflammatory agents you can buy over the counter, like your NSAIDs, so your Advils, your Aleve, your naproxens. Those are also have been mentioned in the media as anti-inflammatories, so maybe they help with cognition. Again, has not been validated, and you can really run into some serious issues, especially in the elderly population, taking NSAIDs over the counter with GI bleeds and potential hemorrhages. So again, when in doubt, always check with your pharmacist or provider to make sure you're not overdoing it with things that are available over the counter. Just because something says it's natural or it's sold over the counter doesn't necessarily mean that it's safe for you. So you should always double check with your pharmacist the next time you're getting your medications filled. Okay, I think I'm ready for my next slide. So besides the FDA approved medications for Alzheimer's dementia, obviously there's a whole slew of medications that are commonly prescribed for the behavioral symptoms that we see with this population. So I'm going to, again, very high level, kind of give you a synopsis of the main classes of medications that we see in this population, good or bad. This is what we see every day. So the first class is what we would call anti-convulsants. So traditionally, these are drugs that were used for patients that were epileptic and had seizures. But they found with patients with Alzheimer's dementia, they could be great mood stabilizers for those that have a lot of agitation and aggression. Commonly, I see carbamazepine, which is pretty effective, but it does require lab monitoring and does have significant drug interactions. So close monitoring by the physician. There's also Lamotrigine is another drug that we see, but this also has some very unique side effect profiles that we often have to monitor even closer than carbamazepine. So again, with every benefit with these add-on medications, there's also side effects that we have to be aware of and have to look at risk versus benefit. Another drug that I see in this class but doesn't have data and has a lot of issues with falls and sedation and other quite serious side effects is Valproate Acid. We try to avoid this one, but I do see it still prescribed. The next class, which is a huge class, there's many different classes within this this group, this category of antidepressants. The main thing we're going to focus on is what we call SSRIs. So antidepressants have showed mixed results in this population with Alzheimer's patients. I think it really kind of depends on what the picture was with that patient before they were diagnosed with Alzheimer's dementia. If they already had a depression diagnosis and had been on a medication, that's something where it's easier to titrate. But adding on when you don't have that history, it's kind of a mixed bag on where the prescriber goes with that. The couple of medications that we see are Citalopram or Celexa. It has some effectiveness that we've seen in this population, similar to another drug that I'll talk about in the antipsychotic category. Also, the main one that we see and that has the best outcomes and results is Sertraline, which is the generic for Zoloft. That one has more data. It's great, easy drug to titrate in this population, and it's been around a long time, and so it seems to have the least risk in this population. Another medication that you'll commonly see, especially in like a skilled facility or an assisted living facility, is the medication Trazodone. This is a very, very old drug, and often it's not used as an antidepressant anymore. It's often used at bedtime at low dose because the biggest side effect with this medication is drowsiness. And so it's, for someone that already has, issues with sleeping and you mix this bag up with the Alzheimer's dementia, maybe some depression, this is commonly added on by prescribers, again, usually at bedtime, because it does cause drowsiness. So that's something to be aware of. Again, if they're already on something like Celexa or Zoloft, and then the prescriber adds on this Trazodone, you just need to make sure the prescriber sees the whole picture and they've looked at everything. Because when you have multiple prescribers, sometimes these things get missed and you don't want to overdo it again with this drug class. But again, low dose Trazodone is usually fine. But again, because it causes drowsiness, you really need to be careful for fall risk at nighttime. So if they're getting up in the middle of the night to use the restroom, this is where we run into issues with the Trazodone because it does cause a lot of drowsiness. So the next class I briefly touched on, this is a very, again, I want to say controversial, but it's we'll talk about a list of medications that we try to avoid in the elderly population, and this is one of them. However, I think pretty much everyone that I've come across over the years that has agitation or psychosis that is severe because of Alzheimer's dementia is on one of these medications. And these are what we call the antipsychotics. So these are your risperidones, your quetiapine, so your Seroquels, olanzapine, apiprazole. The benefits of these medications from a clinical perspective are very minimal. it's just, there's a lot of issues with side effects, especially in anyone over the age 65 with other chronic conditions. There's a lot of metabolic effects with these medications, but sometimes you get to the point with the agitation with these patients that you're kind of stuck, and the prescribers get stuck, and we end up putting patients on these. And so we just have to monitor them very, very closely for any side effects, and just, you know, making sure again that your client or your loved one is responding to this medication in a beneficial way. There's going to be side effects to any medication, but if this is you know, helping you get through the day a little bit easier, or helping them sleep a little bit easier, those are like the risks and benefits that we have to step back and look at that patient specifically, but also understand that as clinicians, we have to be monitoring them closely to make sure they don't have any detrimental side effects. The next class, the anxiolytics. So these are medications like your benzodiazepines, so your Valiums, your temazepams, lorazepams, all of the M's. And we really try to avoid these. Like, these are like, do not use, and anyone over 65, like black box warning, don't use them. So I feel like, especially in California, the prescribers have really cleaned up patients' lists, medication lists per se, because they were kind of forced to by the accrediting bodies, but they still pop up. They're still necessary, but only for short-term use. And so that's, you know, when someone's in an acute crisis and they're having like a panic attack or an anxiety attack, these are when these medications are used. But because there's such a huge risk, A, for dependency, and B, for fall risk in our patients over 65, we really avoid these. I think the only one that we see that has some limited data is Buspar or Buspardone. Again, has some anxiolytic properties that can help in this population. And then finally, our sleep aids. So we call these the Z drugs, our sleeping drugs. So again, these work very similarly to the anxiolytics, the benzodiazepines. They can really get people in trouble, especially for people that have cognitive decline and dementia symptoms. So we really try to avoid these medications at all costs. If, again, you're in a bind and it's the only way, again, it's short term. If some traumatic event happened and they need to take it for a few days, I've seen that, but honestly, long term, I don't think any prescriber would ever do that, especially in this population. Some alternatives are, from a natural therapy perspective, is melatonin. Melatonin is something we already create naturally in our body, and so it's pretty safe. Again, I'm starting to see mega doses of everything these days, so in moderation. I know if you take too much melatonin, some people get headaches and things like that. So it's like 3 to 5 milligrams is all you need of melatonin. And what it does, it just resets your sleep cycle. I don't think that's as easily maintainable in someone that has Alzheimer's, dementia, cognitive issues, but it's a safer alternative than what we call the sleep drugs, like your Ambiens and Sonatas and things like that. Next slide, Vanna. So I just want to touch on a few things as we kind of finish up the medication part. You know, the medications that, you know, we take over the counter or by prescription, you know, they all have risk, they all have benefits. So it's really important that you always have a conversation with your doctor, your provider, or your pharmacist about necessity. Do an annual medication review, looking at, you know, the dosing. Is your dosing the appropriate dose? I have many clients that have been on a starter dose for like 5 years, and their physician either forgot or they changed doctors, and they never got titrated up to the appropriate therapeutic dose. So they've been taking this starter dose that hasn't really been giving them any benefit, and maybe potentially getting some side effects from this medication. And so these are questions, you know, that working with a pharmacist or, if you have a relationship with a provider, that you can really make sure, is this working for my client or for my loved one? Also looking at, timing of day of medications, as Amy was speaking to earlier, it's tough some days trying to get people to take their medications. And if you don't take them, they can't work. And so we talk about compliance a lot in my little world, and getting timing of the day based on how the drug is prescribed is a tricky thing. And, I know some people get stuck on like, it has to be every 12 hours. And it's like, yes, that is the ideal situation if it's every 12 hours. But if it's like an hour here or there, it's not going to be the end of the world with most medications. I'm not going to say that for all, but for most medications, there's a little bit of wiggle room. So again, going back to what Amy was saying, being flexible. And if it doesn't work out that day, start over the next day. Also looking at, again, the options for the medications as far as the dosage forms. I touched on that with the medications at the beginning, that there's different options, whether it's something they have trouble swallowing or they have high pill burden. These are all things, that your pharmacist can work with you on to make sure that you're getting the medication in a way that works for your loved one or your client. Also looking at therapeutic substitutions. Again, the amount of drugs approved by the FDA for Alzheimer's dementia is very limited, but there's always options, like I had mentioned with the Nemxeric, looking at a single pill versus 2 pills. And then also, just knowing what to do if you accidentally take a medication or the medication is given twice. Different caregivers come in. It's important to, understand what to do if things are done incorrectly and how to respond. And most of the time, it's not the end of the world, but it's important to understand what your options are. I will do I think the next one. Okay, perfect. Yes. So speaking of, taking things incorrectly and, understanding their medication regimen. So storage and disposal, Amy touched on this in her portion of the talk, keeping the space uncluttered. From my perspective as a pharmacist, safety of the medication is the utmost importance, not only to the person taking it, but those around them. And when you're dealing with someone with cognitive decline and memory issues, it's important that you have a system in place so that they're not accidentally taking 2 days worth of medications in one day. Or there's things available on the floor that an animal can get to or that a child can get to. I always joke when I give my talks normally about the medicine cabinet. It's like the worst thing in the world from a pharmacist perspective, because it's the worst place you could keep your medications. So obviously a medicine cabinet's usually in a bathroom where it's humid and hot and the temperature is not regulated well. So please never keep your medications in the bathroom where humidity and different elements can get to them. It's important to keep your medications in a dark, dry area where they're not exposed to light and extreme temperatures. Often the kitchen, on an upper cabinet where, again, only the people that need to get to the medication have access to it. Also looking at expiration dates. And if you accidentally give someone something that's expired, like, is it okay? And having those conversations with your pharmacist. And then once you've had your med review and kind of decluttered your medications or things are expiring, how are you going to get rid of those medications? So we should never dump our medications down the sink or the toilet. There's different tips that I can share with you guys in the Q&A, but using your coffee grounds to like put the medications in there and kind of like divvy them up. If there's what we would call controlled substances, we would definitely not want to put those in the trash. We want to take those to like a prescription drug drop-off location. In San Diego County, pretty much all of the sheriff's offices now, they used to have limited, but I think all of them now have some sort of drug drop-off location, and it's almost like a mailbox that you just open and throw it in there, so that again, things aren't getting left out in the trash for people to be exposed to. And one last thing about exposure. Whenever someone is using what we call a transdermal patch, it's super important to always fold that over itself before disposing of it to, again, make sure a child or an animal are not being exposed to the medication that's embedded on the inside of the patch. Even if it's been used, there's still some residual in there, and it can cause a lot of issues. So that's kind of the main thing with storage disposal. I have tons more tips on that. Kind of talked about this already. Again, using boxes or reminder systems. I give my clients what we call a med tracker, where we track things on paper. There's so many apps and bells and whistles out there, but I've found from my experience, especially in a setting where someone's trying to live with this disease in the home setting, you often have multiple people helping them. So you'll have family members, you may have hired help coming in throughout the day. The person themselves may not be is advanced enough in the disease that they're still able to take their meds, but then they can't remember later in the day. So we love just using paper and a little grid for tracking our medication. That way, no matter who's there through the day, you have a clear picture of what's been happening. And then Amy touched on swallow precautions, again, looking at dosage forms that are available for the different medications, and making those decisions based on your client or loved one. And I think we have one more slide after this. Yes. I think this is Amy's slide, right? Or do you want me to keep going? Sorry.
Nope, this isn't me. This is you, but I'm happy to jump in.
I'll keep going. Sorry. So again, looking at, which medications, we talked about earlier with, people struggling with timing and dosing of the medications. And so again, when you're looking at someone, refusing or not wanting to take their meds, if you can try to get them to take, their Aricept first or their Seroquel first, the things that are going to help them and help you make it through the day. And then later on, if you want to try to get them to take those supplements or little things that you think are helping them, that's something that you can do on later in the day. And as far as, the timing of medications, certain medications need to be taken in the morning. Some, like I mentioned, trazodone, need to be taken at nighttime. So it's important, again, to come up with a game plan with your pharmacist to make sure, again, if you have a high pill burden load, which ones should be taken at which time. And then obviously, watch for the sneaky pocketing or hiding of medications so that we can make sure that, again, we're actually taking the medications and they're not ending up in a side drawer somewhere. Okay, so, and then as far as, I touched on drug interactions with each of the individual medications. Also, there's, obviously alcohol has its own effects on cognition by itself. And then when you combine it with these medications, it can really have a negative effect. And so in general, we advise to avoid use of alcohol in this population purely because of the cognitive issues. I understand some people, that's not an option. So again, having that conversation with your pharmacist and, thinking of alcohol as a drug, that's something that they need to know when looking at the whole picture, because, we definitely want to avoid prescribing these high dose trazodone and things like that if we know that there's a lot of alcohol consumption. And I had mentioned throughout the entire presentation, there's like a list of medications that we just absolutely do not give people over the age of 65. It's a very exhaustive list. It's called the Beers list. And speaking of alcohol, it has nothing to do with alcohol. It actually was created by a pharmacist whose last name was Beers, ironically. And it's evolved over the years. And it's, again, a very exhaustive list. And again, half the medications we discussed today are on this list. So again, it's not, you can't take them. It's just, you want to avoid them if at all possible. And if you can't avoid them, make sure you have your pharmacist or physician constantly reviewing and looking at the side effects. And I think Amy is going to be able to send out a link to share with you all if you want to preview the list. But again, don't be scared by it, because again, it's not you can't take it. It's just work with your provider or pharmacist to, make sure that your loved one is cared for appropriately and being monitored properly if they're on this medication. And
thank you. And yes, we will be in the follow-up email that goes out to everybody later today. We will include a link that will tell you more about the Beers list, and it also links to the full exhaustive list if you want to see the full list of drugs on the Beers criteria from the AGS. We'll send that out shortly. So Ellen, what questions have come in that we can answer?
Wonderful questions. Due to time, I'm going to combine two. I have a question about effectiveness, two-part, and a question about side effects. So for effectiveness, one, how do you tell if the inhibitors like the Nmda, the Aricept, all those types of medications are no longer effective on the symptoms of dementia? And then also, how can you tell if you're starting off at a particular dose and the doctor's increasing it and the doctor says, oh, it may take up to 3 months for you to see an effect? How do you judge the effectiveness or whether it's not working overall?
Okay, great questions. Yeah, so effectiveness is a tough one because again, everybody is different and has a unique response to the medications. But in general, like I had mentioned, we usually start low with a medication and titrate up to make sure we're not getting any side effects. So to figure out if a drug is effective is, again, it's not going to reverse any symptoms of dementia. It's just going to slow down the progression. So when you have a loved one starting on these medications, you're just looking for any significant decline in their cognitive function. So you just don't want it to get worse. And also looking at the side effect profile. Are they having like major GI distress or major side effects where, again, it's just not worth it? If you're noticing when they start it, that it seems to be working, again, it's not going to be like a night and day switch. It's going to be a slow progression. And then, it's been like 5 years, 8 years. It might be something to, again, go back and have a conversation. Like if they started on Aricept and then they added on the Nmda and things are kind of progressing and doing well. And then sometimes they may, as their disease progresses, they may pull back the Aricept and just leave them on the Nmda. So again, there's no perfect formula for everyone. Everyone is unique, and you, again, have to have that relationship with your provider. And just, again, if you don't have that relationship with your provider, if you've had to switch doctors, try to have a relationship with your pharmacist and noting what's going on with that client or patient. And honestly, you as a provider, or sorry, the caregiver or the loved one, the family member, you are the best medication advocate for yourself and for your loved one. So keeping a journal in our like little med tracker that we give out to our clients, we have a space where they can take notes. And so you can go back a year and kind of see like how they're doing with their activities of daily living and how they're progressing. I've had some clients where we wean them off the Aricept and they were less kind of lethargic during the day. Again, it didn't make them like jump up in their chair and, do jumping jacks, but it was just a little thing that the family noticed. So again, it's not for everyone. Some people are on these drugs forever. It's just, it can vary. It's a very mixed bag, unfortunately, with this disease, because it continues to progress no matter what drugs we throw at it. And so looking at effectiveness is very patient specific.
Thank you. That's a great answer. The other question, I say it's a great answer because it helps me personally. But also, what about side effects? Unfortunately, sometimes people are prescribed medications that can, for behavior, for aggression, anxiety, paranoia, that can cause, for example, sleepiness, drowsiness. And there is a question of, are they being over medicated? Will their body get used to it? How do we judge this type of situation?
Yeah, I agree. There are probably too many medications being prescribed. Again, it's not a one size fits all. Pretty much all of the medications that I reviewed today cause some sort of drowsiness or lethargy or those types of things. Unfortunately, that is the nature of these medications. They're trying to reduce the agitation and aggression, and they suppress our CNS system, and that's how they work. So I think the best answer to that question is, again, anytime a new medication is added on, as a pharmacist, I'm always looking at, can we titrate their current med a little bit more before we add on another medication? Unfortunately, in our healthcare system, we tend to see prescribers adding on multiple medications before they titrate up one medication fully. So not only does that add to your pill burden, but it also, causes what we call polypharmacy and increases your side effect profile. So I would, in a situation like that, where someone's experiencing a lot of drowsiness and a lot of the side effects from multiple medications, I would definitely recommend a medication review, either by the pharmacist or by the physician, or even, some nurses are comfortable doing it with someone that's very versed in medications of this nature, to kind of give some advice to the providers. And oftentimes it could be multiple providers that aren't able to talk to each other, either because they're different facilities or things like that. And so they just are completely unaware that the other provider is prescribing these things. And so again, I go back to, you have to be your best advocate for your own health, and including your medications, because things do fall through the cracks. And again, with these medications, they are all CNS depressants, so they're going to cause that drowsiness and sedation. And so it's, how do we minimize the number of medications that are on that compound it?
Thank you so much.
I know we're at our time here. I just want to add, I want to echo your very important message about being your own best advocate when it comes to medicine. And I would just add to that response that the balance of quality of life and function has to be taken into consideration there. So is the person so sleepy that they cannot function, they cannot do the things that give them, by their own personal definition, a good quality of life, right? Then this is an important side effect. So yeah, thank you so much for that good thought. Yeah, please. We're on the topic of resources for additional help. Yeah. So your timing is good.
Questions. I'm going to offer, I have a little book that I wrote that has all of my tips and things for medication management in the home setting. So if anybody wants a free copy, I will be happy to send it out. Just let Amy or the Alzheimer's San Diego know, and I'll be happy to send it out to anyone that wants more tips on medication safety and being your own advocate.
It's a great book. It's a really generous offer. Thank you so much for making that available. And to all of you who are attending, when we send out that follow-up email, I'll put a prompt in there. If you want a copy of that book sent to you, I'll just remind you to let me know, send an address where you want it to go, and we'll get it off to you. So thank you so much, Dr. Matampore, for that very generous gift to all of us. Really appreciate that. So I will wrap things up here briefly. Just want to mention that a lot of additional support is available. We always want to direct you to talk with your own doctor, talk to your pharmacist, ask these individual questions about your specific situation. And also remember that we're here, right? If you don't have a good relationship with your doctor, you don't know a good pharmacist, right? Reach out and let us know, and we can connect you to resources here in San Diego. It's very important that you recognize when it's time to have a little extra help, have a safety net for yourself, have some backup, and reach out, get connected to these resources when you need them. So at Alzheimer's San Diego, we are a local independent nonprofit organization. All of these supports and services that you see on screen here are provided at no cost to you. So consultation with our team of dementia experts, access to virtual support groups, our online education programs, of course, our volunteer programs, tech support, not only available in webinars, but for you at home too, if you need to learn how to use Zoom or FaceTime to connect with your family long distance, where our volunteers can help with that, as well as making telephone reassurance calls, checking in with people who have dementia and live alone, as well as our volunteer All's Companions program, which offers respite to family caregivers, virtual or in person. We support local research endeavors. We can get you information about local clinical trials, not only related to experimental medication, but other forms of treatment. And our local research community is robust and active and always in need of volunteers. So let us know if we can help connect you to these or any other resource that you need. Ellen has put a link out in the chat. You can fill that out if there is a specific question or a resource that you're looking for. Go ahead and fill that out, and one of our clinical care coaches will follow up. There's a lot of good information on our website. You can also just call, email, or even live chat us directly from our website. So don't hesitate. Let us know how we can help. A couple of education programs that are coming up. I want to make sure that you know about how to talk about memory loss will be held on Saturday, November 20th, on the topic of sort of bringing up difficult, challenging topics, getting somebody to go to agree to go to the doctor to get a diagnosis, talking about bringing in-home care support, having those tough discussions about driving. So it's a talk about talking about memory loss specifically. We'll be holding a drop-in education hour the week of Thanksgiving. Myself, other members of the education team, just available to answer any question that you have. There's no structure, no agenda. Love to have you join us. And then that managing resistance class that I mentioned before will really dive in on techniques for understanding and responding to resistance in people who are living with dementia. So information about all those, of course, is on our website, as well as registration links. So we would really appreciate your feedback on this program, suggestions for other topics and programs that would be helpful to you. So when the webinar ends, you're going to be directed to an online survey. We'd appreciate you taking a moment to fill it out and give us your feedback. It's anonymous, so and they are read and taken to heart. We really appreciate your feedback. So as I mentioned, I will send an email out a little bit later to everyone in attendance here to send you the slides, to send you a link for more information about the drugs that are on the Beers list, the Beers criteria, as well as a couple of supplemental resources. And if you are interested in getting a copy of Dr. Matinpour's free book, then please just reply to that message, let me know, send me an address, and we'll make sure that, that you receive that. A recording of this program will be available in our webinar library in a couple of days. If you want to check back, if there's you want to review something that you heard, or you want to refer someone else to this program, it will be there for you. So my sincere thanks to you, Dr. Matampour, for your time, your expertise. I always learn something new. Of course, the information is always changing, but I always learn something new from you. I really appreciate you giving your time to us here today. And to Ellen as well for all of your help in the Q&A and all the help you provide to our families. And to Tompi for being here to help out with the technical side of things. Couldn't do all this without all of you. So my thanks. Have a great afternoon, everyone, and we hope to see you again soon.